Hey, everybody. Welcome back to the Overrun Podcast. My name is Ed Bouter.
And I'm Dan Schwester.
We are joined again. Josh Kimbrell and Judah Kleinbrook have come out of their medical school caves and their publishing caves to come and discuss with us this brand new data. Josh and Judah, thank you for coming back on the show, guys. I appreciate it.
Yeah, good to see you guys.
So, how's school?
Josh, you want to take that one first? I got to take a sip.
The look was enough.
We're going to have to start the conversation. We don't have 8 hours to get into all of it.
That was the look of a hardened combat veteran.
I know, right? Like, hey, how's it going? Just long stare down the barrel. So,
hey, it's great.
Josh and Judah
time.
just put out this new paper, the American Journal of Emergency Medicine. Guys, we've talked about cardiac arrest a lot on this show. We've spoken with you guys on this show about cardiac arrest. So what you guys looked at here, delays to chest compression and defibrillation after pre-hospital arrest. Great idea, really accessible paper. Let's get right into the meat of it here. Talk about what you looked at, talk about what you found, and what you guys liked about this.
Yeah, so I guess to kind of provide a frame of reference, so kind of with several of our projects that we've done, these have kind of all started out of my kind of quality improvement work with this department. So this is a hospital-based EMS service in New York City, participates in the 911 system and also has some airport responses. And so one area of care that I kind of have become obsessed with is this post-arrest period. We focus a lot, I think, on the intra-arrest period, but I want to know about what happens after and why are some patients rearresting and some patients not. And so one thing that we found actually working with a lot of other projects was that several of these patients had VFib, which I could see on my retrospective review and like CodeStat, the ECG software we use, where there were long times of VFib not being recognized. And obviously there's so many factors in the pre-hospital setting that make that super difficult, right? One paramedic on one side of the, using a scoop stretcher or using sheets to pull somebody out. Nobody's looking at the monitor. Maybe the monitor's disconnected. And so one thing we came up with is, how long are these delays? Can we actually characterize some of these delays? And can we look at how they maybe relate to movement? So that's kind of the genesis of it.
And then I think kind of getting into the movement piece, this is where some of my interest comes in, because I'm interested in rearrest, but I'm very interested in how we measure and define intra-arrest transport, because I think for a while we've had this question of who should you transport and when. And I don't think we've realized that if these patients are really getting transient ROSC and rearresting, we need to be measuring like when we're actually moving these patients, because that's the true moment of transport. It's not when the ambulance wheels start rolling, right? And so Josh had really, I think noticed in his prior project on chest compression fraction that the medics were often disconnecting the cables from the monitor. And anybody that's been in the field for a while, whether you've been, kind of yelled at by your quality officer not to do that or not, it's something that you sometimes just have to do. It's the logistics of the scenario. You're in a tight space, right? And we kind of got to thinking, okay, well, can we both measure these delays, but then also kind of embed into this really accessible study a pilot method to measure when this movement occurs, and then see like when are these rearrests happening in relation to movement? And so while this paper is predominantly about the delays, we also kind of embed this exploratory methodology just to kind of get the ball rolling into the literature to potentially build on via us or other investigators in the future.
Yeah, and this is something that hasn't been looked at a whole lot, so I was really happy to see this study come out. And just for reference, this came out in May. Still pretty new, still being analyzed by everybody, but 235 patients, you had about 50% that experienced rearrest. Again, first data point that I think is really important and exciting to look at is, all right, going into an arrest, there's a 50% chance that your patient's going to rearrest. Now, I understand that the paper only has 235 patients in it, but I think it's very important to say like, all right, any arrest that you get a ROSC on, at least kind of have that in the back of your mind. So, a good N here, you had a good sample, but 10 looks like 10 rearrested in asystole, and you had delays from there. So without, and the abstract is available. We're going to publish the link to the paper in the show notes, but talk to us about, I guess, let's start with the results, right? What you guys found. And then I want to get into kind of the whys a little bit from there, but are we delaying too much before getting into defibrillation? Of course, we're doing this show looking at this paper like, hey, Josh, did we find that we delay during resuscitations, or what did we actually discover during this process?
Well, we did find some delays. And
did we?
I think what's scary is almost the delays that we couldn't look at, but that's probably a different discussion. But what we do know is for patients that had a rearrest rhythm of VFib or asystole, the two rhythms that we can say for sure you did not have a heartbeat with, we know that there was a prolonged amount of time for a majority of those patients to defibrillation if they were in a VFib and to chest compressions. And so we characterize the delay as greater than 10 seconds, right? So some of these patients had a shorter delay and some of them had a longer delay. But what it comes down to is I think all of the things that are going on in that space, we're not always recognizing immediately when that patient decompensates, right? Maybe we'll notice, oh, you know what, that end title's dropping, that pulse ox is getting a little bit lower. Let's look at the ECG monitor. Some monitors have alarms, but frankly, anybody that's used alarms enough knows that you just turn the silence button on as soon as you can. And so, yeah, we found a lot of these patients had prolonged delays. And that doesn't even get to the like more complicated recognition of like, do you recognize when your patient's getting hypotensive, when they're starting to brady down? The patient that's in what I probably suspect is PA is a potentially perfusing rhythm, but I can't say for sure when that happens. How long are those patients not getting chest compressions when they should? I think there's a lot. There's a lot.
And I think there's a lot in training and conversation we have too, where like, remember, your PEA might not be PEA, and they might be profoundly hypotensive, which is true, right? And is an important part of the conversation in resuscitation. But I wonder how much of that is people saying like, oh, well, they might actually have just a very low blood pressure instead of, and going down one route instead of the other. Judah, I want to look at this. There's a couple also for any of the nerds that are reading this paper, brilliant diagrams and box plots that are on this. You can just look at them and just kind of nerd out over that. But you got a couple really good violin and box plots here for the people that are reading it that may not be familiar with these particular diagrams. What am I looking at here? What does this tell me?
Yeah, so you are looking at a plot of the data, and you're actually looking at all of these data points. So the way that a violin plot works is it takes the classic box plot, which you can see on each one is the delays to CPR and asystole and the delays to defibrillation on your right. The dark black line in the middle of the box plot is your median, right? And then that is going to have your 75th and 25th percentiles on the other side of the box. It's then going to throw some of these data points on. And the goal of a violin plot is really just to show you where the bulk of the data is. So it colors in where the bulk of the data lies. So you can see here that the delays in asystole, delays to CPR, specifically in asystole on the left, the bulk of the data actually lie down at the bottom, right? So they're near that 10-second delay cutoff, just above it. But you do also have some data points with a considerable delay north of about 750 seconds there. On the right, you see kind of a similar pattern where you get this concentration on the downside with delays to defibrillation, but you actually have quite a few data points, even for these small samples, that are some pretty scary delays. And keep in mind, these are only the delays that we measured. I think every investigator who's finished a paper wishes they would have done something differently. And I think the 3 patients that received no defibrillation in VF, if we had to do it over again, we would have used the time they probably reached the ED as like an upper cap, right? Because that's probably when they truly got defibrillated, or used when I think a couple of these patients actually were in VF and then they deteriorate out of it. And so using that time.
Well, that's always the fun part, right? We mentioned on Journal Club every week that, essentially what you want to do is you want to have a paper that ends with, more data is needed, more research is needed, and all of this. And then you got one more really cool graph down here that I want to get into before we start talking about what all of this means here. So, and again, when we're looking at all of different, ROSC and rearrest patterns and everybody, we want to be able to see what we're doing, what's successful and what's not. Let's talk about this graph here because this looks like a pretty graph. And I appreciate the color schemes, but talk to us about what this means to someone who's interpreting the data.
Josh, you want to take this one? You love your Sankeys.
Sure. Yeah, we tried to make this even more complicated.
They are really pretty.
Yeah, it is actually a much simpler version than what we had originally tried to do, and we had several sessions to try to get this down. But essentially, your kind of vertical stripes, the one far at the left, the one in the middle, and the one at the right, are different time periods during the course of arrest. So On the far left, we have all of our patients in the study. So that's any patient with ROSC over this time period that was on scene. And then our middle time point is the time of transport, right? And so that's the like timestamp that they put into their like CAD dispatch software typically. And so whether they had ROSC or not, and then whether they had ROSC or not at the ED. So what's interesting here, and obviously there are a lot of oscillations, right? Because you could have rearrested and then got ROSC again before transport time, which is why we were trying to get more levels of data, but it just got a little too complicated. But I think what's interesting to show is that, you have some patients that rearrest prior to transport and then get ROSC by the time they get to the ED. And maybe more concerningly, you have that kind of delayed rearrest that's actually happening in transit, that small sliver that's going from ROSC at transport time down to pulseless at ED. And so this is just showing, I think, the way that some of these like patterns can oscillate, and that it's not so simple as do CPR, do great ACLS, get ROSC, take patient to hospital, right? All of a sudden now we're doing CPR again, and it's a lot more complicated, and those states can transition pretty rapidly. So just kind of a way to show that.
No, and I think that's terrific. I really like the delineation point for the transport times and showing that like people can and do rearrest on the way into the hospital. So we've just spent 10, 15 minutes going through the background of this because I really want the audience to have a really good understanding of what it is this paper was looking at. So 10,000 foot view, what did we find, guys? What did we learn that we didn't know initially? And then we're going to go into how to fix all the world's problems.
Josh, you want to take the delays findings, and then I'll do the movement?
Sure. Yeah. So I think what we found here is when we were able to measure the time to treatment, whether that's defibrillation or chest compressions, there are serious delays in pre-hospital rearrest care. And we don't know whether that's because of recognition or they're task saturated. They know that the patient's in asystole, but they're trying to say, hey, stop what we're doing. Everybody put everything down. Let's start chest compressions. Let's get the firefighter on. We don't know any of that. All we know,
right? And this was, and you weren't looking for that either. That the idea isn't to find the causative factor. It's more this exists because we can find all the causative stuff later, right? That's frankly what we're about to discuss. But and I think that's an important point too. We're like most academic papers find a problem or explain something that's happening in nature or in the environment. Then someone else comes along and says, okay, Kimbrell and Kleinbrook found this, so now we're going to do this, right? So, and again, because I think I don't want people to read it and go, well, we should fix, like, okay, all we're doing is looking at this very specific issue in time. And so, no, I agree. I'm sure the problems to getting, starting CPR and doing defibrillations again are many and varied. But, before we solve a problem, we have to admit there is one. So,
yeah, absolutely. And I think what it does is you've had these studies now. There's a bunch of them now in the pre-hospital setting that have been like, okay, this is how many patients rearrest, and patients that rearrest do worse than patients that don't. That's not like, well, the patient that loses the pulse is going to do worse than the patient that keeps the pulse. But this is interesting because it's like a potential mechanism and maybe even a modifiable mechanism that contributes to mortality. That is something that we can highlight.
Yeah, no, I think that's close to right. Judah, what do you got for this?
Yeah, so I think, in talking about the delays, we embed this piece about the movement. And if you look in the paper, you'll see that we weren't able to measure this time of movement on everybody because not all paramedics decided to disconnect the monitor. There's no real way to know when a patient is moved. It's not something that the Utstein guidelines say to collect. It's not something that's been collected in any study to our acknowledgement. If you actually look in our discussion, we cite papers that try to estimate this time the patient movement began, and they do it just via a rough estimate of, it's probably about 5 minutes before the transport time. Well, if you look at our movement time, you'll see that, and you can see this in the paper, especially I believe it's table 3, if I'm not mistaken, that we had 55 patients that had the movement time measured or inferred. And of these patients, we saw that a majority arrested before or shortly during the movement period itself when that monitor was disconnected. Now, the way that we know that somebody arrested during movement, it's actually quite interesting. So when we were looking at these strips, if they went into the movement period with a pulse, with a rhythm compatible with perfusion, and without transthoracic impedance, a measurement of the boingy boings, as I like to say.
Boingy boings.
We'll go with a really scientific term there. You wind up with this picture of you have patients that are rearresting during the movement period, right? And you even have patients that are rearresting afterwards. I would caution anybody from saying, oh, it's the movement that caused anything here. But as a descriptive finding, is just saying we have a problem here. It does look like, one, these patients are rearresting in and around the movement time. Two, there's a lot of variability in the time from patient movement to true transport, and a lot of variability in how long a patient is in movement. And this fits with kind of our clinical experience, right? If you've done this for long enough, you know that if somebody arrested in public, it's a 2-minute shot into your ambulance and to get the wheels rolling. If somebody arrested in the bottom basement, especially in a place like New York, it's going to be a while till you get them out of there and you get them to the truck and you get the wheels rolling, right? And so I think that while it's a preliminary method and we don't know if it's valid, to be honest. We don't know if when somebody unplugs and replugs, that's truly the only times the patient, is moving. You can get into a whole conversation on how we measure this. But we know that those rearrests are happening in and around that period of time, and that it's really variable. It's kind of the two main takeaways I would
Right.
say.
And I think the equipment disconnect is a good surrogate for movement. I think that's probably right. Like, generally speaking, if you have to move someone, the easiest thing to do is to disconnect them off the monitor. So I think that's perfectly valid. And I think you're right. I don't know if there's any real way that you can find, the moment someone rearrests.
It's as accurate as you're going to get right
Yeah.
now
Yeah,
without
short
some
of-
kind
short
of
of
wireless
and
technology.
like looking at all the strips and seeing when someone actually like signs out, you're not going to have it. So
Yeah.
Dan, going through this paper,
Okay.
I think the movement thing that Judah's talking about is really, really important. Josh's
Yes.
stuff on the fact that this happens, right? Yeah, patients are going to rearrest, right?
Mhm.
I think we look through papers like what can be changed, what can we add to this. I don't know that there's anything that we can do about patients that rearrest.
I got a few things.
I'm ready for it.
All right. First of all, I love this paper, guys. This was awesome. It was unique. It's something that nobody's looked at in the past. And it's going to spur a lot of ideas in the way of human factors and what we need to do to measure this to figure out what we're going to do for the next step. Like Ed says, Ed's favorite term is saying we don't know what we're doing in cardiac arrest. And I think it's probably a combination of things, but a lot of it is we just don't know it yet. We don't understand it fully. We don't understand what happens to the body in the milliseconds after they convert. What happens to their shock state when they reperfuse? We don't know. And we're not going to know. But this is a great idea. So the second thing I would take from this, and this is like from a practical, what does this paper do for me? What it does for me is tomorrow when I go to work, if I get a cardiac arrest and I get ROSC, we're not moving right away. We are going to sit there for 5 or 10 minutes. And the reason why is we are going to optimize ventilation. We're going to optimize their BP. We're going to start pressors. We're going to do all this stuff while we're getting ready to move because it's going to take them 5 or 10 minutes to get it ready to move anyway. Let's take that time to optimize this. And then when we're moving that patient, it may not be me. It may be the brand new EMT cadet with the bright orange Dayglow shirt. And I'm going to tell her, I want you to watch the screen. If anything changes, you tell me.
Anything. If anything changes, yeah.
I'm not asking her to interpret. She's my safety. Okay. She's like, oh, hey, something doesn't look right. I don't care if I look 50 times.
Well, that's what was
between
Judah saying
there
when
and the ambulance.
If the bloop bloops aren't bloop blooping anymore, I need you to tell me.
Exactly. The most important thing here is this is a very physiologically unstable patient. And we've never been taught this. My medic school experience was, hey, you got ROSC, good for you. You're a hero. Go pick up your sticker or whatever they gave you. And we didn't realize what was coming after. We didn't realize how unstable these people are. Nobody's ever taught us. And now the evidence is pretty clear. Hey, look, if we don't do this, we're not going to get as many people back as we should. And like I said, I love this paper because it points out, hey, you turn your back on them for a second, You unplug because you think you got to get up somewhere. Maybe you're doing it because it's easier. Maybe you're doing it for true logistics. I don't know. It's a dangerous time. Maybe you shouldn't. I don't know. What do you guys think?
Yeah, I think it's tough, right? So the limited literature we have on this does not suggest that there's a huge benefit necessarily to waiting a specific amount of time on scene, but I think that makes sense. I'm with you. I think we should have, I've heard it called a tactical pause. You wait 10 minutes, everybody sit there, set up the norepinephrine. Even if you're not going to use it, have it ready. Closely watch ventilation. If you have maybe if you haven't got an advanced airway in place, get an airway that's going to be definitive for the duration of the transport. It might be a time to get additional access if that's something you feel like you need. This is your
Use your
time to
ventilator.
get everything out. Yeah. I mean, this is the time for you to go recheck your H's and T's, check your own pulse, take a deep breath and look. I think that makes a lot of sense. I think there might be a rule for as artificial intelligence gets better and better and stops hallucinating as much. Maybe there's a way for the new monitors to actually say, hey, we think this patient's going to rearrest in 2 minutes. You guys should start paying attention. I don't think we're actually that far from that. I think there might be a role
You
for
need like one of those medical droids from Star Wars, like Empire Strikes Back. That,
exactly.
Hey, listen, we just got an offer. We just got an AI offer. Everyone can get med beds now, so we're all going to be perfectly healthy, and we live in a Star Wars future now.
Oof.
But
yeah.
but Josh, I think that's a really good point, and I want to get to a couple other things. But Judah, give me some of your feedback on that too.
Yeah, so I'm going to take a, not, I wouldn't say a contrarian kind of view to, this whole idea of a tactical pause and whatnot, but show how there's a secondary benefit to it. Because I think we think of the tactical pause as benefiting, we're going to prevent the rearrest. I'll be honest, y'all, we don't have the evidence to say that right now. It's a highly unstable medical condition. We have no randomized controlled trial that has shown that even anything that we do will prevent rearrest. I think that the precautionary principle begs us to help our patients and to do what is wise. But I think that our paper slides in this secondary benefit to the tactical pause. And that is that if they rearrest in a setting, if they're going to rearrest, they're probably going to rearrest soon. And if they do, we're likely to miss it and not get on the chest and not defibrillate. And so maybe the outcome of interest that we need to be trialing is not only did you prevent the rearrest, but for the ones that occurred, how quickly did you get back on the chest? How quickly did you defibrillate again? Because the idea here is that they got ROSC. That means that you were able to optimize their physiology enough to get that event. You can probably do it again. But if you're rushing, if you're moving, if you're delaying compressions and ventilations, we know in initial cardiac arrest that that's harmful. Josh and I have had some interesting academic discussions of do we even really need to look at the question of does a delay in getting back on the chest or rearrest, does that associate and or cause detrimental outcomes? Because we already have the evidence in initial arrest, right?
Mm-hmm.
I
Right.
would lean towards maybe, that research can be done when it's a little easier. But right now, I think it's kind of the precautionary principle and trying to optimize what's in place, not just for rearrest prevention, but also to get back on the chest and treat really.
Yeah, I think that's absolutely right. And one of the cool things that can come from papers like this, where it's not necessarily a direct result of the data that's out, right? But you might find secondary and tertiary things. So what Josh was saying is I like the idea of, all right, this paper suggests that a third of your patients who have a ROSC are going to rearrest, right? So going into that now, just having that knowledge, maybe this patient isn't part of that third, but I can start developing a routine where, I have norepinephrine ready. I have another regular epinephrine ready. I have stuff available to me to reduce that window when they rearrest again, right? So I think if nothing else, just pointing out, raising knowledge, raising, awareness that we're doing this is something that can lead to better outcomes. And I certainly think that if you're a medic that's in the field and you're seeing this, great, now I've got a patient with ROSC. Instead of going, up, ROSC, let's get up and move, take that second and say, all right, what can I do now? Right? Because your patient's presentation has changed. They may have initially been a cardiac arrest. Now they have a different physiologic presentation, right? Almost to the point where you could almost argue that's a second job, a second dispatch. So getting to that point and saying, all right, now we have to add these things, we have to do these interventions and these treatments. I think just kind of having that in the back of your head is important. As far as the delays to compression, I think it's very interesting how you guys got to the data that you got. And AHA and ILCOR, they've come out with a bunch of different new ideas. Maybe after a ROSC, you stay on scene for a little while. And, if not, continue doing compressions, watch them a little bit. Do you guys feel that this kind of adds to that body? Do you feel that your findings were inconsistent with anything? Or do you feel it kind of adds to sort of where the trend in cardiac arrest is going?
I think the only thing that's a little contrary, and the thing that might be a sticking point for some, is in the extracorporeal ECMO guidelines,
You can do it.
ELSO.
I love that you gave up.
I was about to try to say it and I gave up. A lot of those
Extra.
guidelines actually use they want these patients going straight to ECMO. So these patients that are in and out of rearrest. And so there's this decision where you have to decide if your patient has 3 rounds of VFib in their rearrest, are you going to stay and stabilize that patient and try to reduce the time to defibrillation? Are we just going to go to the ECMO center because it's only 12 minutes away and I know I could drive really fast and really, really cool person is there that'll do the cool procedure and everybody be excited. So I think maybe a little bit of tension there. I think that ultimately before we didn't know if waiting longer on scene would help, and now we still don't know, but we think it's a good idea. So maybe it pushes slightly in that direction, but I think it'd definitely be tough to have this kind of descriptive paper actually move the needle on those guidelines, but it certainly should generate some discussion and hopefully some more research.
Yeah,
You guys are truly humble.
I mean, I think that's like what needs to happen in scholarly endeavors. I'll be honest, there's a lot of papers that people publish and it's like, oh, we found this amazing thing and we think it's going to be, a game changer. Reading this paper, it's a single center paper. It's descriptive. We're not able to say what caused these events, and this is a kind of sticking point that Josh is probably going to begin spurking, is I always talk about causation. I'm obsessed with how we infer causation from observational data, whether we need trials, whether we don't. And I think this is a situation where right now I talk about this precautionary principle. And those who are listening, that's just fancy nerd speak for we don't know, but physiologically we're reasoning that we need to prevent rearrest and we need to get back on the chest quickly. But Josh raises this counterpoint and this tension that systems are beginning to move towards ECPR. We're starting to see systems in major cities moving to where these patients have a indication per the recent guidelines to get ECMO. And right now, ECMO is majority in hospital in the States. Until it comes pre-hospital, you have this tough decision to make when you go for ECMO in these patients. I would argue that the longer your patient can get a ROSC, multiple ROSCs, and circulation, even if they rearrest by the time they hit the doors, their lactate and their physiological markers before they go on pump are probably going to be better. But I'm not currently in the majority, and we don't have a lot of data to answer this question. And so I think that getting a lot of the medics who are listening to this, I think continuing to treat these patients with care and continuing to talk to your medical directors and talk to folks that are in your systems of care to really figure out, can we publish small descriptive studies on how we're handling rearrest patients with ECMO? Right. I think that's going to be a big thing in the next decade or two. Something I can say I'm looking forward to researching as a young resuscitation scientist. I think these are perhaps our most viable patients, right? They got a ROSC and then they've rearrested. They might have an occlusion. They might have a massive PE. They might have an aortic dissection. But if we don't optimize the amount of time that their native circulation is running, I'm afraid that we're going to be transporting people that then won't go on pump, right? And that might wind up costing our systems in the end.
And I think that's one of the things that I think is very fascinating about researching EMS. As someone who's moving into professional academia myself, is the data. One of my favorite catchphrases on this show is the data is extant, and it's not in EMS. We suck at researching EMS. And so, anything that, like I said, that can add to that corpus of data where we can look into data that affects, rearrest after VFib, right? That data, it has been out for 40 years. But when we add the variable of pre-hospital environment, and now there's 5 guys who looked at it. And, so any research in the pre-hospital arena is something that can add to that sort of literature base and kind of add to the discussions. That's probably the first thing, right? Is, we say this as young academics in the industry, people have to do research for there to be evidence out there, right? And So, and looking at this, yeah, Judah, I think there's a great idea. Like, put VV ECMO on every medic truck, right? Train everybody up to get out there, put out
No.
resuscitation teams, send them all out to do all the things. And all that stuff sounds great, but we're not there yet. Right? Like that's something, yeah, if time and money and
No way.
training were no factors, yeah, phenomenal. I think that we should put VV ECMO in a drone and send it to the house just in case.
You laugh, yeah.
But
It's
you know,
With
but
an
until we have that kind of
app-based video instruction
exactly, yeah.
I don't know if you guys
hosted by
know
Matt.
this. I don't know if you guys know this, but like my primary grant right now that I'm training on is drone delivery of AEDs. So
There he is.
now-
Yeah.
Here it goes.
See?
Here
So
it
like
goes.
there's plenty of room for all this stuff, but again, it's like all that stuff sounds great, but if we don't have people doing compressions in the field, then it doesn't really matter what we're doing. Right?
Yeah,
So
exactly.
having the, like, this is the pre-hospital thing. And again, we talked about this earlier, finding out why is something we can do later. Right? If we're not doing compressions for 5 minutes and people are dying because of it, that's something that we need to know. Right, Dan?
Yeah, I agree. And like I said, obviously talk to your medical directors, the usual stuff, engage them with this stuff. But that being said, I think this is just common sense stuff. And like I said, like you guys, it moves the needle. I think it does move the needle a little bit. I think it adds to that burden of proof that we can show that I would feel very comfortable going in to talk to my medical director with the stack of papers and saying, hey, we should put a pause here. We should consider a bundle of care here because I think we would get better results. That being said, common sense, you can do this without any of that stuff. Like I said, just take your time, check your pulse, watch everything. I think the next step for this would be to see what the human factors are with the delays to getting on the chest and the delays to defibrillation. I'd really be interested to see if it was almost like a psychological, like I worked all this time to get this guy back. This can't be happening again. It's not, I'm not seeing what I'm seeing, right? Well, you are. How many times have we checked a pulse on somebody and go, is there? All right, go ahead, do compressions. It's like,
Wow,
is
the
what it
patient's
is.
pulse correlates to mine.
Yeah. I think there's also something here though, and we touched on this a few times, and I don't know if you guys share this opinion, and I say this not as a researcher where I'm supposed to be neutral and non-judgmental, but I don't think there's any excuse in 2025 for missing VF for minutes and minutes and minutes and minutes and minutes.
No, absolutely not.
I think that there's a lot of factors that go into that. I think that I could easily have been a medic that did that, but I think that it is, in the world of quality and safety, it is a never event. That should never happen, ideally. It is like leaving a sponge in the patient.
But I'm going to go back at you with this, Judah, is that may happen, but we have to examine those ergonomic factors, those human factors. Why did that paramedic not recognize it? Why was there such a delay? What factors were involved that delayed him from going, bad squiggles, push button?
Yeah. Well, and
I think that's where this type of research begets better research.
Yeah. And this is the kind of stuff that, like I said, kind of builds into my work, is where, if we're disconnecting patients from the monitors and we're missing VF rearrest, where I come into is like, why are we disconnecting the monitor? Now, because there's a million reasons to do it, right? It could be environment, it could be setting. You don't necessarily want it to be comfort with the patient's presentation, right? But I mean, we've all had your routine chest pain where like, all right, I'm going to go set up out in the truck. I'll see you out there, right? So, I'm interested in finding out how institutionally we get to that point and how we, allow it, how we fix it, whatever. Because again, I think that gets way down to, you get down to the individual level where you might have someone that thinks that the Stryker monitor is heavier than the Zoll monitor, so it's easier to disconnect it, right? Where we're not, and that may or may not necessarily be true, but it's just, there's going to be individual factors that we're never going to be able to
It may be that
for.
simple.
Yeah.
It may just be that simple.
It might be, okay, someone's got a ROSC. We've overlooked this thing, right? So you've got a ROSC. Now we're going to move them. It might just be the common thing that we disconnect people while we're moving them, right? But again, the important stuff is that now we have this information out, right? So we know about this. So this is a third of your patients are at risk for rearrest when you have someone in VFib. Josh, Judah, I'm going to give you guys the last word, and then we're going to get out of here.
Yeah, sounds good. I think one thing that I would add is you don't have to do like more research to find out more about this necessarily. If you're a leader in your organization or you're just a really active paramedic, Like, are you measuring how many patients have rearrest? Are you looking for delays? That's actually probably going to get you a lot farther than doing another study, is trying to make an impact within your own system. Because if you're not measuring something, you can't possibly improve something. And you definitely can't learn about why it happened. So getting in your own system, trying to make an impact there, and trying to like spread awareness there can make every bit as much of an impact as an article in some journal, right? So those are my
Amen.
And for leaders who are looking over data, this is stuff that you can find on the back end in your tech, whatever monitor system you have, whatever EPCR system you have, it is integrated into your system. And if you're not aware of it, you have to talk to your people to find that integration. But you can find really, really good CPR data on the back end.
Absolutely.
No, I echo what Josh says. I think that for those wanting to use this data to potentially kind of on the ground make some improvements, I think the first part is quality on an individual level, watching for this and maybe implementing some of it in your practice. But I think on a system level, agency level, thinking about quality activities. Are you measuring it? If you're measuring it, are you also measuring your treatment delays, right? Not just measuring how often it happens, but are we treating rearrest? Because there's actually somewhat of an academic argument. If your system's really good at getting people back, you might wind up having more rearrests because you get 50% of patients back, but you have a higher numerical number of rearrests because you're so good at getting them back. These things aren't known, right? So you
Good
can start
point.
with quality activities, and you don't need to go trying to publish something for generalizable knowledge. I think the main takeaway from this paper is you should realize that delays in the treatment of rearrest are just as common as delays in treatment of initial cardiac arrest. I think that we've shown at minimum that there are delays and that they appear to be clinically relevant, at least by time. I think the second thing is that in a lot of situations, we're influenced to disconnect the monitor. And if we use it as a surrogate for movement, it appears that there are probably around 20% of patients that are rearresting during that movement period. So maybe considering staying in put, or if you're not going to be able to stay in place, at least being really vigilant when you move.
No, I think that's all good. Danny, what do you got?
Yeah, I can't say anything more. Just remember, any peri-arrest patient, anybody what we get ROSC on, that is a very physiologically fragile patient. You need to optimize things before you're ready to move. There's nothing wrong with it. And again, if you want to get in a bundle of care or start developing stuff, hey, go talk to your people about that. But take the time, make sure the airway's good, make sure the monitor is on, make sure somebody's watching the monitor. Okay. Even just to say, hey, something's weird, something changed. Doesn't matter. Okay. We know the reality is it is what it is out there, but these people we don't get them a lot. They're really, really fragile. We need to pay attention.
Yeah, I think all that's right. And like I said, I think that one of the interesting things to come from this paper is a third of your patients may rearrest as you're moving them. So, and we've spoken plenty of times on this show before about having your pressors ready, having whatever additional treatments you're going to have ready, maybe taking that moment after you get a ROSC and planning for everything as you move out to the hospital. Lots of good stuff here. Really good information. Take the time to watch your patients, monitor them, assess them as you're going through your cardiac arrest algorithm, and especially after you have a ROSC phase. Josh, Judah, it's been so much fun talking to you guys. We're really lucky to have your friendship here. I know you guys are super, super busy with all the little stuff that you guys are doing, publishing and taking over the world in medicine one day at a time. But thank you guys so much for coming on this show. I know you guys have busy lives and busy work. Congratulations on all your stuff you have coming up in the next couple weeks, months.
And good luck.
And good luck on everything. For the uninitiated, Josh and Judah have decided that they're going to make their lives as busy as possible during medical school. So really, really, really give you guys a lot of credit for it. But thank you all for listening to the Overrun. Check us out on YouTube and everywhere else where you get all the stuff and whatever. Subscribe down below. And for the Overrun, I'm Ed Bouter. He's Dan Schwester. And Josh and Judah are still here on camera. So we'll talk to you all next time. Thanks for the Overrun. Subscribe to the thing. And we'll talk to you next time.
Take care, everybody.